Thank you, Acting Secretary Gibson, for being here. And thank you, Chairman Sanders and Ranking Member Burr, for our continuing focus on the issues and challenges facing the VA. When the issues relating to wait times first arose over a month ago, the situation was described as an emergency. There was a sense of urgency. And I want this committee and this Congress to continue to be motivated by the sense of urgency and to continue to recognize that this emergency needs to be addressed, because there is every potential for other issues to come to the fore and for Congress to be distracted, important as these other issues may be. We owe it to the veterans to stay the course. And so I share the sentiments of the chairman and many of the members' statements this morning that we need to hear from you as to your short-term solutions in addressing the issues at hand, and over the long term to address the systemic problems and challenges facing VA. I, like so many of my colleagues, have been visiting with the veterans in my state, frankly, long before the particular crisis arose. And of course, they have shared with me their concerns about the lack of doctors, the changeover of doctors, and those are some of the practical considerations that they've raised with me. And so most of us, I think all of us, have had the opportunity to talk with veterans in our communities one-on-one, and we have a commitment to make sure that we continue to stay the course. That, to me, is the most important thing that this committee can do. And I thank the chairman for not allowing us to move on to other matters that may be pressing, but what could be more pressing, them to make sure that our veterans receive the care that they need and deserve. Thank you, Mr. Chairman. Thank you. We know there are capacity issues at the VA, and I just would like some clarification on some comments or statements that you made. Did you say that based on your assessment of the capacity issues that you would need 10,000 additional staff? I think you were talking about some $17.6 billion that you would be requesting?
That is correct, yes, ma'am. I know that sounds like a huge number. There are 300,000 people in VHA alone.
So is that 10,000 additional staff, and I know you broke it down to how many doctors, et cetera, and within the specialties, et cetera. So is that for the emergency situation we have now, or is this an assessment that reflects your long-term staffing needs?
There was a reference made in one of the opening statements earlier about the findings of the field audit, and the number one cause for scheduling difficulties was that there weren't sufficient provider slots to be able to schedule patients into. So what we're talking about here, my comment earlier that we have not historically managed to requirements, we've managed to a budget number. And so basically we took a budget number and then we did what folks thought they could do. And the veterans wound up being the shock absorber in that process.
So meanwhile, if you look at what your true needs are, then you're saying that you would need hire 10,000 additional staff.
Yes, ma'am.
And that would, of course, depend on the appropriations that we provide.
Yes, ma'am.
So if you were to have the appropriations to hire 10,000 people, how long do you think it would take for 10,000 people to be hired? Because one of the things that I did hear about the hiring in VA is that it takes a long time to hire a doctor. So I hope that in your review, you're also looking at your hiring processes, because it shouldn't take a long time, whatever that means. So that's one question. And then to hire 10,000, do you have any sense of how long this would take should you get the money from us?
A couple of comments. One, at every single medical center I visit, I hear from rank and file staff that it takes too long to hire. So staffing practices is one of our areas of concentration. My guess is there's some of those things that we're going to find that just a function of being in the federal government, and that's the regulation and statute that we've got to follow. But my guess is that we're going to find a large portion of that is self-inflicted, and we've got to clear that stuff away so that we can hire more expeditiously. Second, round numbers, I would say in VHA, we probably hire 30,000 people every year anyway. So I know 10,000 sounds like a huge number. It's about 3% of staff, maybe a little bit less than that. But recognize that some of these are in places like primary care physicians and mental health providers. And we know, and you all know, that those are tough to find. And so it will take time for us to be able to hire them. Quite frankly, the other problem we had, even if we could go out and hire them all tomorrow, we don't have a place to put them all. So in some instances, what we're going to have to do is deal with some of the space issues in tandem with this. We may be able to do, there are actually some provisions in here for what are called emergency leases. I actually authorize some of these when I go out to the field where somebody's found some clinic space that's local, that can be occupied quickly, 10,000 square feet, something like that. They can go put 3 patient-aligned care teams in there and take care of an additional.
Excuse me, I don't mean to interrupt you, but my
Yes,
time
ma'am.
is running out. And
Yes, ma'am.
my concern is mainly that you are addressing the length of time it takes. And if you're hiring 30,000 people every year, there are probably some retention issues that you are also probably addressing.
10% turnover. That's not,
Oh.
in fact, it's relatively low as you look at
That's good.
healthcare organizations.
You have mentioned that in response to a question, that when the IG has findings, to quote you, we're embracing those findings. And since the problems and challenges at the VA have been longstanding, I wonder whether you have a process or someone in the VA who provides a response to the IG's findings. Should you be providing a report to Congress to respond to the IG's findings so that we also can provide the kind of oversight that Congress should provide as to what is happening at VA?
There are responses to those, and unless I'm mistaken, I believe that those responses are shared. Is that correct, Philip? Yes. So there are responses. What I would tell you is that I don't believe that those have always gotten the visibility and the attention. You know, some of the examples surrounding the Office of the Medical Inspector and some of those reports, quite frankly, I don't think those were getting the attention that they deserved. So as we look at overhauling certain of our processes, part of what we've got to do is make sure that the issues that need to be elevated all the way to the Office of the Secretary are in fact being elevated.
Yes.
And that where somebody says we've taken care of this issue, that we know what's been done, and we have confirmed that.
I just have, Mr. Chairman, just one more item. I was told by the veterans that I've been talking with, many of them live on neighbor islands, so these are rural issues. And I was told that even if they got vouchers to go out to get private care, that the doctors on the Big Island, Maui, they wouldn't take veterans, so it wouldn't help them. Have you heard that concern?
I would tell you there are issues around PC3 primary care close to the community contract that we've got with 2 different national providers for specialty care, and we do find instances where I think we've got room for improvement. That's a new program just launched earlier this year, and I don't think we're executing it as well as it needs to be executed. And there are discussions going on this week, today, with the leadership of those 2 programs to make sure that we address those issues. I get that feedback from staff and from veterans as well when I'm out in the field.
Main thing you're addressing
Yes,
that
ma'am.
issue also. Thank you, Mr.
Yes, ma'am.
Chairman.